Waldenstrom's macroglobulinemia case series experience at PGH Chandigarh. So, going to introduction. So, disclaimer is this is a very preliminary analysis. We have to still mine into the data. So, I am going to present a preliminary survival analysis and a detailed descriptive analysis. So, introduction, Waldenstrom's is a rare B-cell lymphoma with an annual incidence of 3 to 4 cases per million per year. Data from India is lacking, as my previous speaker said. There are few case series from his own institute, from DMH, AIMS New Delhi and RCC Trivandrum. But only survival analysis was done only from SGPGI and RCC. The other two studies were only descriptive studies. So this is a heterogeneous disorder with varied presentation due to lymphohematopoietic infiltration by lymphoplasmacytic cells, or into atypical sites such as CNS, which is called Bing-Neal syndrome, or paraneoplastic manifestations such as Raynaud's, cold agglutinin, hemolytic anemia, etc. So going to the methods, study design is a retrospective study analyzing data from the patients diagnosed with a WM from June 2011 to September 2023 with a median follow-up of 55 months. The setting it is conducted at a tertiary care center in northern India, PGI Chandigarh. Data collection was done reviewing the case records of patients diagnosed with WM. Their clinical, laboratory, treatment and outcome characteristics were noted. Diagnostic criteria used is Mayo Clinic criteria, which is presence of more than 10% clonal lymphoplasmacytic cells and IgM paraprotein in the serum. Risk stratification employed was IPSS-WM, which includes age, hemoglobin, platelet count, beta-2 microglobulin and serum IgM levels. The outcome measures analyzed were overall survival, overall response rate, the response criteria, which is CR, very good partial response, stable disease and progressive disease, according to IWWM 6th International Workshop consensus criteria. So statistical analysis performed where descriptive statistics were used to summarize the patient characteristics. Kaplan-Meier analysis was employed to estimate overall and event-free survival rates. Cox proportional, I have written it here, but we didn't use it because we have to still mine for the data to get answer to these variables. So all the statistical analysis were performed using SPSS software version 11. So going into the results, demographic characteristics, mean age was 62 years with standard deviation of 10. Males were predominant around 75%. Clinical symptoms, only 2 patients were asymptomatic at presentation and the predominant symptoms were anemia, around 87%, followed by constitutional symptoms, bleeding and fever. The IgM related symptoms were present in around 23% of the patients. Out of them, predominant was peripheral neuropathy. And massive splenomegaly is seen in around 7% of the patients, 7 patients. So coming to laboratory and prognostic characteristics, median hemoglobin was 7.5, platelet count was 1,10,000, and the median IgM level was 2.8. IgM kappa was predominant, around 67%, and heavy infiltration of the bone marrow was seen, which is more than 50% of the infiltration in the bone marrow in around 39 patients. And peripheral spillage was also seen in around 8% of the patients. So for calculating prognostic scoring, we don't have IgM and beta-2 microglobulin for all the patients. So it was missing in around 40 to 50% of the patients. So after excluding those patients, we analyzed for 38 patients, which were low risk 3 patients, intermediate risk 7 patients, high risk 28 patients. Coming to treatment characteristics, patients treated at our institute, the 2 patients were not treated, they were observed. The rest of the patients were treated with these regimens, predominantly DR 41%, RCDEX 24%, chlorambucil or cytoxan with dexa or prednisolone in around 18% of the patients. The rest of the regimens were given to a very small number of patients. And treatment indications, as shown there, symptomatic anemia was the predominant indication for treatment, followed by thrombocytopenia. splenomegaly, cold agglutinin disease, and peripheral neuropathy. The outcomes were analyzed as responses, which is overall response. Only response could be analyzed in only 35 patients. After excluding patients lost to follow-up, patients who were not having baseline IgM or follow-up IgM level. So the overall response rate was around 82%, which includes CR, VGPR, and PR. Progressive disease was seen in 5% of the patients. And the overall response rate with respect to the regimens, BR had an overall response rate of 25%, RCD 28%, chlorambucil or cytoxan based had a response rate of 8%. So 5-year overall survival analysis showed 70.8% overall survival in the cohort and event-free survival of 74%.
Okay, any questions, any doubts? Topic is open for discussion.
Many patients had hyperviscosity or
5
had
patients.
changes.
Yes, ma'am.
Yeah.
5 patients.
5 of them.
Yes. One had CRP,
Okay.
yeah, one had 7th cranial nerve palsy, other symptoms, renal failure.
And hematological.
Hematological in the form of symptomatic anemia, thrombocytopenia, massive splenomegaly.
Immune hemolytic anemia.
Yes, yes, ma'am.
Cold agglutinin.
5 patients.
5 patients. Oh, I'm sorry, I missed that.
Five patients.
Okay. Thank you.
How do you decide this very good partial response? What is the criteria for that? Very good partial response, difference between complete response and partial response.
So in Waldenstrom's, we usually use IgM level rather than SPEP, which is usually used in myeloma for response assessment. If IgM protein decrease is more than 90% of the baseline, then we call it as a very good partial response.
Okay.
For calling it as a CR, you have to have a negative IFE, SPEP, and a negative infiltrate in the bone marrow and resolution of all splenomegaly, lymphadenopathy, everything.
Thank you, Dr. Raji, for informative and simple presentation.